Hello everyone, welcome to my YouTube channel Easy Nursing Lectures. Before starting the class, please subscribe to my channel and share to your friends. So our today's topic of discussion will be abortion. So what is the normal definition of abortion is the pregnancy loss in less than 20 weeks of gestation or when the fetal weight is less than 500. So any pregnancy loss in less than 20 weeks and the fetus weight should be less than 500 gram. So this is the criteria of abortion. Then we can define it as the abortion. So in this picture, as you can see, that there is behind the chorion there is bleeding, this red color part, so that does not let the placenta to attach, and because of there will be bleeding will start. So this is the pervaginal bleeding, and contraction will occur in the uterus. So because of that contraction, there will be a high risk of the fetus to get expelled out. So this is the main phenomena of abortion. What are the causes? The causes may be fetus embryo. Mostly this is the cause. Any congenital malformation, any genetic issues into the fetus or embryo. Then maternal hormone support. If the mother is suffering from PCOS, diabetes, hypothyroidism, so these may be the causes of maternal causes of abortion. And last is the causes of the endometrium, like the attachment problem of the placenta. Okay, next is bleeding followed by pain according to the size of the uterus. So this will be the sign of abortion. So we will discuss each type of abortion with one case scenario. So first case scenario is we have a 25-year-old nulliparous woman who walks into the OPD with 1.5 month period of amenorrhea with slight spotting for 2 hours. So 1.5 month is about 6 weeks. With the slight spotting, now you have to catch these words. Spotting is there for 2 hours. She does not complain of any pain. Pain is not there, spotting is there, and 6 weeks of amenorrhea. She has done a home-based pregnancy test which was positive. So she is telling that her pregnancy is positive. So we have to rule out first whether the mother is pregnant or not, and blood loss is how much. So pregnant for 6 weeks, that is 1.5 months, blood loss is spotting. Okay, how do we proceed with this now? We have to do a clinical confirmation of her period of gestation from the last LMP. Okay, so confirm her period of gestation, then we go for an investigation. In investigation we will do USG, or more better option is transvaginal sonography. Along with that, on pelvic examination, the uterus is about 6 weeks and the os is closed. Okay, you can see in this picture the os is closed, and the pelvic examination, the uterus is about 6 weeks. That means the size of the uterus is corresponding to the period of gestation, plus the os is closed and entire content is inside. You can see this is the entire content which is inside, and mild bleeding, that is spotting, is there. So how do you define this condition? This is likely diagnosis is threatened abortion. Okay, that means this is a warning and abortion has not yet started, but there will be an abortion. So that is called as threatened abortion. How will you confirm the diagnosis? By transvaginal sonography. So in this transvaginal sonography, as you can see, this is the product of conception. Okay, this, and this is the uterus outer. So fetus is inside uterus. The crown rump length, that is the head to the this length, crown to the rump length is 5 mm. Okay, plus the cardiac activity of the fetus is present, and there will be a subchorionic hematoma or hemorrhage in the transvaginal sonography. So this is the TVS report of the threatened abortion. And how do you manage this condition? This condition is managed with conservative management. Okay, so you have to give reassurance to the mother. You have to tell her to avoid any strenuous activity, that a patient with threatened abortion should not do strenuous activity, should not go to gym, should not go to jump and all. Okay, so these things you have to tell her. Apart from these, there is no medical treatment advice for threatened abortion, and also there is no role of giving any progesterone to maintain the pregnancy. Okay, if in case there is a spontaneous threatened abortion, spontaneous, then the management will be what? Conservative. Okay, so this was about threatened abortion. Now we will go on to the next case scenario, that is 25-year-old nulliparous pregnant woman comes 1.5 month of amenorrhea. Okay, the vitals are stable, BP is normal. Vitals are stable, BP is normal, pulse rate is normal. She comes with mild bleeding for 2 hours. Now there is mild bleeding for 2 hours. Also she is complaining of cramps in the lower abdomen. Cramps with pain in the lower abdomen. Okay. On pervaginal examination, what do we find? We find that the uterus is 6 weeks in size, that is 1.5 month. Okay. So whatever she has given history on pervaginal, we have got that uterus is 6 weeks. That means size of the uterus is equal to the period of gestation. Then os is open and mild bleeding is seen. Now here the os is open. In previous condition the os was closed. So what will be the likely diagnosis? Okay, size of the uterus equal to the period of gestation. Os is close, open. Mild bleeding is there and content is still inside. Okay, so what is this? This is nothing but inevitable. Inevitable means this miscarriage will 100% occur. You can't do anything. So how will you manage it? We won't go for any procedure in this condition. We won't do any we won't insert any instruments and clear out the things. We have to let it progress on its own naturally. As long as the woman is hemodynamically stable, we will the bleeding per vagina is under control and not severe anemia is there. Then what we will do, we will let it progress on its own. If in these conditions, then intervene surgically. Okay, if the bleeding per vagina is high, mother is not hemodynamically stable and she is having severe anemia, she is looking pale, then you have to do an intervention surgically, and along with that you have to give resuscitation to the mother. So this was all about the inevitable abortion. Now we see the next case scenario number 3. There is a 25-year-old pregnant woman with 3 months of amenorrhea, that is 12 weeks. There is no pallor, pulse rate is 90, BP is 110/70, bleeding for 2 hours. Also soaked 3 pads fully, cramping lower abdominal pain. Okay, bleeding for 2 hours, 3 pads have been soaked in 2 hours. The pulse rate is 90, BP is 110/70. So the mother is hemodynamically stable first of all, but bleeding is increased. On pervaginal examination, we found that on pervaginal examination we found that the uterus is 6 weeks in size. Okay, but in the scenario what we have seen, that 3 months of amenorrhea, that means 12 weeks. And here on pervaginal we are getting 6 weeks. That means the size of the uterus, okay, size of the uterus is less than the period of gestation. That means something has gone out from the uterus. Size of the uterus is small. The os is open and also active bleeding is there. Okay, so what is the likely diagnosis? Size of the uterus less than period of gestation. Some products are still left into the uterine cavity. Okay, and some are going out. There is active bleeding. The os is open. Contents are partially expelled. So this is nothing but incomplete abortion. some products are there, some products have been expelled out. How do you proceed with this condition? Now you have to go for an USG. In USG you will find hypoechoic white patches into the USG. That is nothing but these are some retained products of the conception, and we need to expel it out. Okay, so to expel it out, we will do some medical management. We will give the mother tab misoprostol 400 to 800 microgram. If mother is hemodynamically unstable, BP is excessive, okay, and woman wants it to clear out as soon as possible, then we will go for a surgical management. That is nothing but suction and evacuation or dilatation and curettage. Okay, but more precise is suction and evacuation. Now we will see the case scenario 4. We saw threatened abortion, then incomplete abortion. Now we will see case scenario 4. A 25-year-old nulliparous pregnant woman with a 2 months of amenorrhea walks into the OPD with bleeding per vaginal for 4 hours. Okay, 4 hours continuous bleeding is there, 2 months of amenorrhea with cramping lower abdominal pain. Also, she soaked 3 to 4 pads fully, but now the bleeding and pain has subsided. Bleeding reduced, pain subsided. What has happened? They have done PV examination. They felt that the uterus is bulky, the os is closed. Os is closed. Active bleeding is not there. Abortion is done. Okay. Size of the uterus is less than the period of gestation because mother is telling 2 months of amenorrhea. Okay. Woman can give, also the os is closed, so product of conception might have gone out. Woman can give also the history of passage of fleshy mass per vagina. Sometimes women may not notice because when they go to the washroom, when they go to the toilet, they won't see what is coming out. But sometimes if some fleshy mass is coming per vagina, this history you can get. So what we'll do, the next step is we will go for a transvaginal sonography, which reveals that the uterus is bulky in size and the cavity is empty. Cavity is empty means the whole product of conception has gone out. So the final diagnosis will be what? It will be complete abortion. How do we proceed with complete abortion? Nothing specific to be is required after this. Very important is counseling. Why? Because the woman might have wanted the pregnancy so much, okay, and this has happened to her. So it is the medical professional's duty to counsel her, and it is very important. So this was about complete abortion. Now next to last scenario, that is a 30-year-old multiparous woman is wheeled into casualty. Now into casualty means something emergency is happening with a severe bleeding per vaginal for to past 2 hours. Cramping is there, abdominal pain is there. She is extremely pale, means her HB is low, pulse rate is 110 high, BP is 80/50, that is low. So mother's vitals are unstable, she is hemodynamically unstable. So first of all we need to resuscitate her. Okay, start IV fluid, wide bore cannula, arrange blood, immediate investigation to be sent. Okay, by the side we will take a quick history. Quick history mein we have to ask her about her pregnancy status. Now when a woman, young woman of the reproductive age comes to your emergency, anything, you have to confirm her pregnancy. We have to see her for any bleeding per vagina, and rule out pregnancy. How do you proceed with it? Ask about history of amenorrhea. Also ask about history of any pill taken. Okay. On examination, you find out that the abdomen is soft and her undergarments are completely soaked in blood. Then you do a pervaginal examination. You find out that the uterus is 6 weeks, the os is open, and the period of conception can be felt in the vagina. That means period of conception is felt, some part is there incomplete, os is open, and size is less than the like size of the uterus is less than the period of gestation. So it is an incomplete abortion along with shock, because mother is having her PP is low, her pulse rate is high, she is in shock. How will you manage? First of all, resuscitate the mother and immediate evacuation of the period of conception. Okay, after you immediately evacuate the period of conception, then only there will be, like, whatever antibiotics you are starting, it will respond and do suction and evacuation or DNC. So next is how to summarize the topic is, we have listed all the abortion what we have seen: threatened, inevitable, incomplete and complete. So here you can see in threatened, the period of the product of conception is still inside, mild spotting of blood is there, the internal os is closed, there is fetal cardiac activity is present on transvaginal sonography, also spotting is there, and size of the uterus is equal to the period of gestation. In inevitable, product of conception is inside, mild bleeding is there, cervical os is open, okay, open. Fetal cardiac activity might be present, might not be present. Then bleeding will be there, bleeding will be more, size of the uterus will be equal to the period of gestation. In incomplete, some product of conception is still there, bleeding is there, cervical os is open, and fetal cardiac activity is absent, bleeding per vagina will be excessive plus or minus shock, size of the uterus will be less than the period of conception. In complete, there is no product of conception, okay, the cervical os will be closed, no fetal cardiac activity, bleeding per vagina will be high, but after some time it will stop, and size of the uterus will be very less than the period of gestation. Okay, now we will see the septic abortion. What is septic abortion? Contents of the uterus are infected and the infection is spreading upwards. Okay, it is not common more in cities because there is a high facility. It will be mostly common in villages where the health facility are not reached properly. So one scenario we will see: a 16-year-old female came, unmarried girl, who was referred from a PHC with 5 days of high grade fever and chills. Okay, she had first received 2 days of antibiotics. Initially she was sent to home and her HB was 10 gram, her TLC was 10,000. Then her fever worsened at home and she developed vomiting, diarrhea, abdominal pain. Then she was admitted in PHC where she was given IV fluid, empirical IV antibiotics for the treatment of typhoid and started. USG was not performed as it was not available. Then she came to a higher facility. So on examination she is looking completely pale because her HB is 10 mg per DL. Her pulse rate is high, her BP is low. Okay, that means she is hemodynamically unstable. Her abdomen is distended, guarding tenderness and rigidity. Okay, so this is a sign of peritonitis. Foul smell in vaginal discharge is there. So what have we missed? We have missed the history. You have to ask history about amenorrhea with possible pregnancy, and some local dai had did some intrauterine intervention. Because of that she has got an infection. So most likely diagnosis is what? It is a septic abortion. So what is the management of septic abortion? Is supportive care to the mother, resuscitation for shock, IV antibiotics. We will start high broad spectrum antibiotics before any investigation reports. We won't wait. Then you send an investigation, CBC, TLC, DLC, vaginal swab culture. Then you will get a culture sensitivity test. On basis of that you can start the relevant antibiotics. After the patient has settled, you have to do a transvaginal sonography to rule out any perforation or any contents inside. If content is inside, you have to evacuate it as soon as possible so that the antibiotics respond to the treatment. So this was all about abortion. I hope you understood everything. Thank you for listening me patiently, and please subscribe to my channel and share this class.